So now I'm very upset because I am from Peru and we are playing France. I don't know how you expect.
There's still hope. It's a break.
Okay, good. I don't know how you expect me to concentrate. I'd like to thank the chairs for the kind invitation, and it really is a pleasure to update you on what's been happening over the past year in bile duct cancer. So just a very quick single slide introduction. We are dealing with a global problem, but in fact, in the UK, where I work, and most places in the US, it's quite a low prevalence condition. It accounts for about 3% of GI malignancies. And you can see for cholangiocarcinoma on the left and gallbladder cancer on the right, that there's quite a lot of geographical variation with hotspots, particularly in Southeast Asia and specifically Thailand for cholangiocarcinoma, and South America, Chile in particular, and northern India for gallbladder cancer. So the remit was to look at the data for the last year, and I want to talk to you about the phase 3 BCAT study, which was in the adjuvant setting. I'll focus a little bit on treatment of advanced disease, the FUGA-BT study, as well as the BIL-MEK study, which was looking at the addition of a MEK inhibitor. Quickly talk about new promising agents and combinations, and please forgive me ahead of time if I don't focus on your particular trial of interest. And then close out by talking about new data coming from the International Cancer Genome Consortium, as well as what that means in terms of studies going forward, either looking at single targets or, in fact, basket and umbrella studies. So in the adjuvant setting, we know that surgery offers the one and only chance of a long-term cure. And this is the study that was published just a few weeks ago, which was the BCAT study, the bile duct cancer adjuvant study performed by Japanese colleagues. This study was limited to patients with extrahepatic cholangiocarcinoma. That includes perihilar tumors as well as distal cholangiocarcinomas, and treatment was started within 10 weeks post-op. And it was a one-to-one randomization. It was a phase 3 study to either observation alone or to gemcitabine in the standard regimen for 6 months, 6 cycles. Patients were stratified by the known prognostic factors of resection margin status, lymph node involvement, primary tumor site, and center. And the primary endpoint here was overall survival. Secondary endpoints are as shown. The original target was for 300 patients to be recruited. The study recruited 225 patients, at which time it was closed. And this is the efficacy results in terms of relapse-free survival on the left and overall survival, the primary endpoint, on the right. As you can see, the addition of gemcitabine in the adjuvant setting for these patients did not confer a survival advantage. Unfortunately, this was a negative study. Moreover, it appeared that no subgroup benefit, particularly node positive or resection margin involved, and this goes a little bit against the study that came from Princess Margaret, looking at the retrospective series that suggested that patients with node positive disease are the ones that might benefit from chemotherapy. One point to note, however, is that the survival, the 5-year survival of patients in this study was better than anticipated in the original projections, thus 50% versus 30%, and this is a common theme. We've now seen 3 studies come in the last 18 months in the adjuvant setting, and in all 3 of them, the survival has been better than anticipated, leading to a prolongation of the time required to complete the studies. So just to put it into context, I've already shown you this. This is the BCAT study. The study presented at ASCO GI last year was the PRODIGE 12 study, and this had relapse-free survival as the primary endpoint, and unfortunately this was also a negative study. The addition of GEMOX in the adjuvant setting did not improve relapse-free survival over surveillance. I've actually shown the Kaplan-Meier curve for overall survival. That is in contrast with a study that was presented at main ASCO of last year, the BILCAP study, which was the largest of the 3 studies, which showed a benefit for adjuvant capecitabine chemotherapy, but only in the pre-planned sensitivity analysis. So in the intention to treat analysis, in fact, this failed to reach its primary endpoint, but it had failed to take into account lymph node status. And so when the pre-planned sensitivity analysis was done for lymph node status, in fact, there was a 30% reduction in risk of death with a statistically significant p-value of 0.07. And this is just to quickly show you those two Kaplan-Meier curves. On the left, the intention to treat population. On the right, the per protocol analysis with numbers which are very similar. The patients in the observation arm survived 36.1 months, improving to 52.7 months, which is a difficult delta to ignore when discussing this with a patient. So this is where we're up to in terms of the modern randomized phase 3 studies. 3 are now completed and reported. You can see that most of the studies, barring the BCAT study, included both cholangio and gallbladder cancers. The BCAT is the only study that specifically focused on extrahepatic cholangiocarcinoma. The last 2 studies, the ASCOT study was adjusted in terms of sample size. That was increased from 350 to 440. That study is about due to complete recruitment, I think, around the summer, and that's comparing observation versus S1. And the ACTICA-1 study, which has been done in Germany, has now been modified to change the control arm from observation to capecitabine, and that's comparing effectively combination chemotherapy versus monotherapy. So I just want to highlight some differences in the study population because although we talk about biliary tract cancer, these are a very heterogeneous group of patients. And I've just highlighted here, I've already said in the BCAT study, it only looked at hilers and distal cholangiocarcinomas, but the PRODIGE study was actually very heavy on intrahepatic cholangiocarcinomas. Both the BCAT and the PRODIGE studies had very similar numbers of patients who had negative lymph nodes. That was much lower in the BILCAP study as shown in red. Similarly, when you look at the resection margin involvement, this was very similar between the BCAT and the PRODIGE studies and much lower in terms of a clear margin in the BILCAP study. And I've just put here the experimental versus the control arm. And what I want you to do is have a quick look at the control arm. When you're comparing across studies, if your control arm is behaving very differently, that's telling you you're dealing with heterogeneity between the clinical studies. And you can see here the overall survival in the control arm is quite different between these 3 studies. So I think we have to be very cautious about extrapolating the results or comparing them between the studies. We very much need to take each study in its own merit. What about radiation? This is not new. This hasn't been published in the last year, but it's really the direction of travel. So on the basis of this phase 2 multi-center study, patients were treated with, patients with extrahepatic cholangiocarcinoma or gallbladder cancer who were considered to be at high risk because of advanced T-stage, end-stage, or involved margin, received GemCap chemotherapy followed by chemoradiotherapy. And the bottom line on the left is that the threshold of activity was met for this to be considered an active regimen. So the next obvious question in the adjuvant setting is where does radiotherapy fit in? And this is now being considered in terms of study designs. For example, the ACTICA-1 study is now considering inclusion of radiotherapy as a randomized question specifically in patients with R1 disease. Moving on to advanced disease. When the ESMO guidelines look relatively simple, it tells you that there's really not much evidence based on which to make treatment decisions. The exception, I guess, to biliary tract cancer is the fact that we've got a standard of care first-line chemotherapy with cisplatin and gemcitabine. And in Japan, this has also been shown to be the case. So the BT22 study was a randomized phase 2 study that had a survival advantage in favor of combination chemotherapy compared to gemcitabine alone. And in fact, when we meta-analyzed the results between that study and the ABC02 pivotal study, the median overall survival was 11.6 months. As you know, in Japan, there's an interest with S1, and the JCOG 0805 study had asked the question whether gemcitabine on S1 was better than S1, which was considered an active agent at the time. And you can see here in this randomized phase 2 study, the Kaplan-Meiers clearly show that there is an improvement from combination chemotherapy versus monotherapy with S1. So it won't surprise you to hear that the next study was looking at gemcitabine and S1, and within the FUGA-BT study, the comparison was cisplatin gemcitabine versus gemcitabine and S1, and this was set up as a non-inferiority study rather than a superiority study. The regimens are as shown. And these are the results that were presented at ASCO GI and again at ASCO just a few weeks ago. And you can see here that these curves overlap, which is what you want to see when you're looking for non-inferiority studies. So the hazard ratio and the p-values were within the preset parameters to confirm non-inferiority of gemcitabine and S1. You can see as well that that was consistent across all of the subgroups. The ones with the widest confidence intervals, in fact, just had very small patient numbers. So these were the authors' summaries when presented at the meetings. The primary endpoint was met and non-inferiority was demonstrated. Then there's a little bit of a commentary on whether gemcitabine and S1 was better or cisplatin gemcitabine was better. But really, when you look at the differences numerically in terms of median PFS, response rate, etc., the numbers are quite small in terms of differences. One of the things that they did feel was that because you don't require the hydration for cisplatin, so you don't require the hydration that you need for cisplatin when you're using S1, that it may be a more convenient regimen. And certainly in Japan, I think this offers a new treatment option. Moving on to the randomized phase 2 BIL-MEK study, we know that biliary tract cancer frequently demonstrates upregulation in the RAS-RAF-MEK ERK pathway. This can be targeted, and selumetinib is such an oral inhibitor. There is preclinical evidence suggesting that this is the right thing to do, and in particular that it needs to be sequenced with gemcitabine. Tony Bekai-Saab at Ohio State University, when he was there, did a phase 2 trial in second-line setting, and this demonstrated safety with a 12% response rate. And the ABC04 study, which we led from in the UK, was the phase 1b study of cisplatin gemcitabine in combination with selumetinib, leading to a recommended phase 2 dose. So against that background, the study, which has been performed in Princess Margaret in Toronto, was a randomized phase 2 study looking at 3 different arms. The one at the bottom is the control arm. This is cisplatin gemcitabine in the standard schedule. And then you can see in the orange bars, in one arm, the selumetinib was used continuously, and the other one, it was used sequentially or intermittently, guided by some of the preclinical work that they were basing this on. The primary endpoint was the median % change in measurable disease at 10 weeks. These are the waterfall plots from the study, and you can see, in fact, they look very similar. And in fact, there was no difference between all of these 3 waterfall plots, and the study didn't show superiority for the addition of selumetinib either concurrently or intermittently. And that was confirmed by the secondary endpoints. You can see on the left progression-free survival, on the right overall survival, and these curves pretty much are overlapping. So unfortunately, it looks like selumetinib probably does not enhance the activity of cisplatin gemcitabine, and there is some translational work still being done by the group to see if any additional insights can be gleaned. In terms of other new developments in chemotherapy, acelerin is a new kid on the block, is a first-in-class nucleotide analog. As you can see, if I can get this to work. Okay. So it does not require the nucleoside membrane transporter that gemcitabine does, and also it is not metabolized by cytidine deaminase, which breaks down gemcitabine. So that allows you to get much more drug to the tumor itself. And the ABC08, the Advanced Biliary Cancer number 8 study, is in fact a phase 1b study of acelerin replacing gemcitabine in combination with cisplatin. This was preliminary results presented at ASCO GI as a poster this year. You can see here the caveats are the numbers are extremely small, and so we're looking at the blue here. But in terms of 1 complete response rate, 3 partial response rates leading to 4 out of 8 patients having a response rate, 50% response rate there. Compare that with ABC02, which is 26% response rate. It is early days, so we have to apply all the caveats of having an early look at the data, but certainly this is encouraging. The study is now completing recruitment, and there is a phase 3 or registration strategy which is currently being discussed. The other development in chemotherapy to keep an eye on is a triple combination of cisplatin gemcitabine and the addition of nab-paclitaxel. This was initially presented at ASCO last year and updated at ASCO GI this year. So this is using all three drugs in combinations. The schedule is shown. In fact, there needed to be a modification of the dose because of toxicity with reduction in the nab-paclitaxel. You can see the median progression-free survival was 11.8 months. The response rate was very similar to cisplatin gemcitabine, but the median overall survival was longer than we saw with cisplatin gemcitabine, so 11.7 months, 18 months in this particular schedule. And in the updated analysis, you can see that so far that level of activity is holding, and this is now going to be tested in a phase 3 study compared against cisplatin gemcitabine. So moving away from standard chemotherapy, in terms of understanding the biology of cholangiocarcinoma in particular, a number of groups have over the past years gleaned some insights. And the themes that are emerging are that intrahepatic cholangiocarcinoma has, in fact, quite a different profile to extrahepatic cholangiocarcinoma or gallbladder cancer. And just to highlight that point, you can see here, if I can get this to work, that with intrahepatic cholangiocarcinoma, you're seeing FGFR fusions and amplifications. You see IDH1 mutations, which you don't really see in extrahepatic or gallbladder cancers. So there does seem to be a particular different profile, not just based on anatomy. Other studies have shown that the liver fluke-associated cholangiocarcinoma, which is common in Thailand, has a different profile to non-liver fluke-associated. And Daniela Sia and colleagues have also proposed that there may be an inflammatory subclass, which is quite different to a proliferative subclass based on their work. And this is that particular paper, in which they were only focusing on intrahepatic cholangiocarcinoma, and they were able to demonstrate that really up to 70% of these patients potentially had an actionable mutation, most of them based again around IDH1, IDH2, as well as FGFR fusions. And it won't surprise you to hear that then these are the main thrusts of clinical trials going forward as potential targets have been identified. Most recently, this is the paper that's published in October of last year from the ICGC, and this looked at close to 500 patients and undertook genomic, transcriptomic, and epigenetic assessment and was able to cluster patients into 4 different clusters. And just to quickly take you through the clusters, in cluster number 1, these are the liver fluke-associated cancers. There was a typical hypermethylation pattern, and they were also enriched in TP53, ARID1A, and BRCA mutations. In cluster 2, this was liver fluke as well as non-liver fluke, but they were characterized by increased gene expression of CT and NB1, the Wnt pathway and the AKT pathway. And you can see that the other thing that these had in common was amplification of HER2 as well as increased gene expression in HER2. Cluster 3 was more of an inflammatory immune-related cluster, and you can see they have the highest copy number aberrations and also upregulation of the immune-related pathways. And cluster 4 are the ones that have BAP1, IDH1, and FGFR mutations. And the other thing to note is that, in fact, the extrahepatic cholangiocarcinomas tend to cluster in clusters 1 and 2. Intrahepatic cholangiocarcinomas tend to cluster in clusters 3 and 4. The other thing they noticed is that, in fact, in cluster 4, patients had a better prognosis. And I can quickly show you the Kaplan-Meier curve from the paper, which is, again, a hard paper to read, but a very useful paper. And I would encourage colleagues to look at that. And you can see in the red that cluster 4 are the ones who have a much better survival than the others. So in terms of targeting these emerging mutations, the first one is IDH1. IDH1, in fact, is a mutation not only associated with cholangiocarcinoma, but also chondrosarcoma, glioma, and others. There's a phase 1 study which has included all of those subgroups. And just to show you the data from the cholangiocarcinoma cohort of 73 patients, this was presented at ASCO last year by Maeve Lowry and colleagues. You can see that the drug was actually reasonably well tolerated with only fatigue, nausea, diarrhea, and vomiting, which was easily manageable. The activity in a heavily pretreated setting was a 6-month progression-free survival of 38.5%. About 1 in 5 patients were surviving a year, and you may recall that this is a poor prognosis group, and it was really on the basis of that data that the study has been taken further. The phase 3 study is currently open. It's recruiting. It's a second-line study, which is randomizing patients 2-to-1 to receive ADJUVANT, a first-in-class oral inhibitor of mutant IDH1 or placebo. And what's particularly attractive to patients is that there is crossover upon progression on placebo. And the other group of patients are the FGFR group who are mutated. Just to remind you, in terms of the FGFR pathway, there are a number of different aberrations that can happen. There can be an activating mutation, there can be translocations, gene amplification, as well as other changes. And the one that's particularly relevant to cholangiocarcinoma, in fact, are the fusions and translocations. The BGJ-398 infigratinib phase 2 trial has already reported and published in Journal of Clinical Oncology. In this particular study, patients with advanced or metastatic cholangiocarcinoma who were harboring an FGFR2 fusion or another genetic aberration in FGFR were included. They had to have had a prior therapy and progressed on that, and they received oral therapy for days 1 to 21 of a 28-day cycle. The primary endpoint was response rate by RECIST. The secondary endpoints are as shown. 47 patients were treated, and as you can see, the vast majority of the patients had FGFR2 fusions and rearrangements in 38 patients. There were some other alterations in 9 patients, FGFR2 mutations, FGFR2 amplifications, and 2 patients had FGFR3 amplifications. This is the waterfall plot from that particular study, and what was particularly noteworthy is that all of the 8 patients who had a partial response, in fact, had an FGFR2 fusion rearrangement. And I've not shown it in the interest of time, but colleagues at Mass General have been looking at the patterns of resistance to FGFR therapy, and it may be that there is also a difference among some of the FGFR inhibitors in that some may be more likely to salvage patients who develop resistance to one targeted agent. So those 2 approaches are very much looking at a single target and having a trial that treats that. In fact, the MOSCATO study is an umbrella study which has 1,035 patients who've had at least 1 prior systemic treatment. This is a study from a team in France. And in fact, through multiple high-throughput molecular analysis, they then allocate a treatment to patients depending on the readout. Now, out of the 1,000 patients, there were 43 with biliary tract cancer, of whom 34 had evaluable tissue, of whom 23 had a druggable alteration, and in fact, 18 went on to treatment. And you can see here that, in fact, of the 18 patients who were treated, the ones in blue are the ones who appeared to benefit from treatment, and these are largely HER2, HER3, and FGFR mutations. And I think the take-home message here is that if you give a treatment on target, the survival is better than if you are unable to give a targeted therapy.
Yeah,
so clearly,
1 more minute.
Thank you. So this is the way, in fact, that clinical trials are now going in the future, and we have a similar study being planned. There are a number of different agents, and in fact, all of those are currently being evaluated in a number of different studies. So take-home messages. The phase 3 BCAT study showed there was no benefit from adjuvant gemcitabine, so we still go back to capecitabine. The FUGA-BT study showed that Gem and S1 was a new option in Japanese patients. The The BIL-MEK study showed no benefit from adding selumetinib to cisgem. There are some new agents, as I've discussed, and promising combinations, and our improved understanding of the landscape and the ability to enroll patients into these much more complex studies actually shape up for some exciting times ahead for cholangiocarcinoma. And just to quickly primarily thank the patient advocacy groups who have done a huge amount, both in the UK and in the US, to engage the clinicians, but also industry and regulatory agencies. Thank you very much.